Good evening. Today we are again meeting for regular presentations of the registrars of family medicine conducted by Sri Lanka College of Specialist Family Physicians. And I would like to welcome you all, and also Madam Lalanta Senaratna, who has joined with us to give the feedback as well as guide us during the presentation. Today's presenter is Dr. Gayatri Nanayakara. She will be presenting about Beyond the Shake, 2 case studies. And I would like to invite Dr. Gayatri to present today. Thank you.
Thank you, Dr. Prabhat, for the invitation. Good evening, everybody. And today I'm going to talk about 2 patients. So as you see, my topic is Beyond the Shake. So both patients are shaking. And as you can see the picture, they are elderly patients. So shall we see how the pattern of their shaking? So this is the first patient. He's 69 years old patient. He came with difficulty in writing. It was about for 6 months and it is progressive. And when I questioned the patient further, he revealed that there's a shivering of his hands and it increases with holding something. And this tremor is for 5 years, affecting not only his hands but head. And when he was stressed, the tremor increased. So this is the brief history. And when I examine, the tremor is involved in the bilateral upper limbs, and it increases with action. And there's no other neurological signs and no features of Parkinsonism or cerebellar signs. So that is the first patient. So the second patient, both of them I encountered in my training period at Base Hospital, Homagama. So the second patient is also 70 years old male patient. He came with the shivering of his bilateral hands for 3 months duration. And it started in right hand first, and it is more prominent in right hand. But now both hands are involved, but more prominent in right hand. He also complains of difficulty in writing. And this patient, he has a resting tremor. So in his rest position, he has the tremor, and it is more prominent in bilateral, in right hand when examined. And in contrast to first patient, this tremor is reducing with action. And in further examination, he has rigidity of his upper limbs, and he had kyphocoliosis. When we inquired, it was congenital, and he had shuffling gait, and the turning was as an block, and he had no cerebellar signs. So my presentation based on those 2 patients. So as you can see, this tremor is 2 different tremors are there. One is when he was doing something. The other one is that patient when he was rest. So the tremor is one of the commonest movement disorder. Tremor is categorized under movement disorder. So mainly tremor is classified into two categories: hypokinetic. Sorry, it is a movement disorder. So movement disorders are classified into 2: the hypokinetic and hyperkinetic. So hypokinetic means slow, hyperkinetic means it is fast. So tremor is categorized under the hyperkinetic movement disorder. The tremor is defined as it's involuntary rhythmic movement. We can also say it's oscillatory movement of a part of the body. So it occurs due to the alternating contraction of agonist and antagonist muscles. And this is the most common movement disorder. So usually we see this thing when it's come to elderly patients, not common in young patients. This tremor can be classified by its distribution, pattern, and according to frequency and etiology. So, my questions to you, what do you think the first thing? Is there anything else you want to know in these patients?
What are the comorbidities he has, and what are the drugs he is on currently?
He had hypertension, and he's on losartan. Other than that, he had no any other chronic illnesses.
I would like to ask Dr. Gayatri, this is for 5 years. Why that he has come now? Is there any worsening of the tremor or something?
Yeah, the tremor was there for 5 years, and there was some kind of a disability with that, but his writing was affected for 6 months. This main concern is his writing disability, because he had... Hello? And he claims to be a security officer, even though he's 69, and he has to report his duty in the book, and he can't write properly. That is why he came to the clinic.
And this patient is having tremor while doing work, like action tremor. So does he have any other cerebral signs?
There's no significant cerebral signs, but he was a bit ataxic, but we didn't take it as a cerebral signs because it was not that significant, and other cerebral signs were not there, like nystagmus.
Gayatri.
Yes.
How about his alcohol consumption? Whether he's using alcohol and these tremors are improving with alcohol, or whether it's aggravated by alcohol?
Yeah, he is not alcoholic, so we couldn't do that test actually.
What about his family history? Family history of similar condition?
We asked that, but he couldn't recall anybody with that. But when we asked from the family member, he said that his parents also had the same condition.
Difficulty in writing mean is it letters are becoming micrographia, or difficult to do the spiral line?
Yeah, it was shivering, like the letters are not eligible. They are not becoming progressively smaller. It is not the thing, but not clear, like shivering. The lines are not continuous like.
Dr. Gayatri, you said that the patient is having ataxia, but you didn't think it as a significant cerebral sign.
Yeah,
is there any for it?
That was the thing. When I go with the main presentation, you will understand that is what I thought actually. Cerebral signs was negative. He was a bit ataxic, but the other cerebral signs, as I told you, the nystagmus, this diadochokinesia or finger nose test was all negative. Hilshin test all negative. So that's why I take it the cerebral signs as negative. Only that one is also there. When I go with the presentation, you will understand what is the significance of that ataxic gait and the ataxic gait with the patient with this kind of a tremor.
Gayatri, other than the tremors, are there any other symptoms? How is his mood like?
His mood is okay, and there's no features of Parkinsonism. You know the features of Parkinsonism, that is tremor. The cardinal features, they are tremor. Tremor is the only one he had from the Parkinson features. There's no rigidity, no bradykinesia. There's no postural instability. And the cranial nerves and the limbs examinations were normal.
Any signs of physiological tremor?
Physiological tremors. Yeah, it was increased by stress. Yes. But the thing is, physiological tremor is always there in anybody, even though we can't see it, only the triggering factors exacerbate it. So, but this patient, when he is doing something, it is there. So I don't think it's a anything. Yeah.
I have two questions. One is how the tremor has initially started. Is it asymmetrical tremor, then progress into both hands and then head? The second one, the presence of any features suggestive of hyperthyroidism.
I'm sorry, who is this? I couldn't.
Sachit.
Okay, Sajita, thank you. Yeah, it started in hands, as he says it was involving both his hands, and then affected his head. And as you say, there's no features of hyperthyroidism. There's no increased sweating or weight loss or increased appetite or increased bowel motions. There's no such thing. I think you are getting the point actually now. You have already excluded so many things that causing tremors. That's good. So what do you think? Yeah.
Case of Fleischer springs.
Sorry.
In the eyes, any case of
Fleischer rings. Good point, Asian. Actually, we didn't look for that. Actually, because he's 69 and there's no features of chronic liver cell disease. I know you are thinking about Wilson's. So we didn't think that in our differential diagnosis. I think because it is very, because we have, we didn't think of that because it is rare. And there's no other features telling that he's having chronic liver cell disease. But I think you are right. We should have looked for it. Thank you.
You told that patient was ataxic. And
yes.
Did he have peripheral neuropathy or any posterior column signs?
No, there was no peripheral neuropathy in that patient.
Mm-hmm. No posterior column signs even?
No posterior column signs. Only he was bit ataxic.
Mm-hmm.
So what do you think? Then now what you have asked from me and what I have told you, we all agree with me that it's action tremor, right?
Yes.
And there's a family history. And there's no sinister signs. So what do you think?
Could be essential tremor.
Yeah, could be, no? Yeah. That is what we thought.
The problem is ataxia. We have
the problem is ataxia. Yeah. So I will tell you what the reason for that when we further discuss the topic. The second patient, I think you already know this name. You 70 years old patient who has rest tremor. Can you guess what the problem here, the condition he
Is it
has.
Parkinson's?
Yeah, because he has all the features of Parkinsonism. So we diagnose it as Parkinson disease, primary Parkinson disease, causing the resting tremor. So I think I discussed this tremor thing. So that what the tremor, even though we think it's not common, actually what I understand is from those two patients I encountered in the second week of my training in the base hospital Homagama. So then starting from the second week until the 8th week, we means the friends with me, we got encountered a lot of patients with tremor, and each and every patient, it was very difficult to come into a diagnosis, what it is, even though they have classified these things very clearly as action rest, but it was very difficult when it's come to patients to diagnose what the tremor is. So that's why I thought of doing this presentation. So when it's come to tremor, tremor is classified into two categories, action tremor and rest tremor. Action tremor means it occurs with action. So it is divided into postural, kinetic, and isometric. Postural tremor occurs when we hold the a part of our body against the gravity. And kinetic tremor means it occurs throughout the action. But in isometric tremor, it occurs when we hold something very tight due to the contractions of this certain muscle group. This occurs. And rest tremor occurs when our part of the body is rest. So in kinetic tremor, we say simple, intention, and target directed. The intention tremor usually occurs in cerebellar lesions. So this is what I told you, the action tremor and its subtypes and the resting tremor. So the resting tremor is mainly the pathological one. The action tremor is seen in the commonest type of tremor, the essential tremor, which is not a pathological one. I mean, it's a pathology, but I mean not a disease like this is coming and there's no identified pathology and there's nothing can be done other than a symptomatic treatment. But the rest tremor, we can treat it. So the rest tremor is mainly caused due to the Parkinson's disease. As you all know, it's a neurodegenerative disease due to loss of dopaminergic neurons. As I told you earlier, there are 4 cardinal signs in Parkinson's disease. So intention tremor, which comes under the action tremor, it occurs in cerebellar lesions. So in there, you get the dysmetria and ataxia, dysnergia, and it can be due to infarction or multiple sclerosis involving cerebellum. And those are the features of intention tremor. As one of you asked, physiological tremor, it is a benign thing. It is invisible to naked eye, but it can be triggered by anxiety or hormonal imbalance like thyrotoxicosis or metabolic causes like hypoglycemia. And if the cause is eliminated, usually the physiological tremor is eliminated. And drug-induced tremor also, it's caused by certain drugs like salbutamol, theophylline, and amiodarone. The psychogenic tremor is different from all that. It has no particular pattern. So here and there it has features of every tremor. So it is there's no neurological signs, and Usually the cause is static, this is not progressive, not worsening or not getting better. And when we observe the patient, usually psychogenic tremor increases. That is the psychogenic tremor. So as I told you, the differential diagnosis of tremor, rest tremor, is the Parkinson disease mainly. And postural and action tremor is essential tremor, which is the most common one. And exaggerated physiological tremor, hypothyroidism and drugs. And intention tremor occurs in cerebellar disorders. In this presentation, I'm mainly going to talk about the essential tremor, which is the most common one. So it is, in definition, it's isolated bilateral upper limb action tremor with duration more than 3 years. Here, isolated means that there's no any other abnormal signs. So, and other than this, it occurs with or without tremor in other locations and absence of other neurological signs. So in definition, essential tremor, there's no dystonia, ataxia or Parkinsonism. But as you see, in our first case, we saw that our patient had ataxia. In some background information about essential tremor, it affects usually about 1% of population, and it's equal in men and women. And there are two peaks, 10 and 20 and 10 to 20 and 50 to 59, but we usually see it in elderly patients. And it says there's significant disability results due to the essential tremor. And often it's familial and inherited in autosomal dominant pattern. The cause is idiopathic. Actually, we don't know what exactly the cause, but thought to be it's due to a cerebellar dysfunction. So when a patient comes to us with the tremor, these are the things we need to see in the history. We need to ask the age of onset, the family history, like in essential tremor, and symptom changes over time. As we all know, sometimes in Parkinson, it's starting one side and maybe go to another side. So like that. So in essential tremor, it's usually bilateral. So like that, we can ask, and we have to take the drug history because sometimes drugs can trigger the tremors, and about the toxins and the alcohol consumption, because sometimes alcohol can suppress the tremor, like in essential tremor, or alcohol withdrawal can cause the tremor also. And these are the drugs that we need to exclude from the history. Few of them are lithium, the commonly used drug, SSRI, theophylline, caffeine, like that. And when it's come to the examination, we need to see whether it's resting tremor or it's a postural or kinetic. With the testing we have to do. Resting tremor, we can ask the patient to find whether it's a resting tremor. We can ask the patient to rest his or her arms on the lap in semi-prone position and see whether the patient has tremor. And when it's come to the action tremor, we can ask the patient to pick something like a pen or something, ask the patient to pour some water, like that we can check the action tremor. And when it's come to intention tremor, we can ask the patient to do finger nose test, discoidal nasal testing, like that we can test that. And always we have to make sure we do the full neurological examination in a patient with tremor. And when it's come to this essential tremor, specific pointers to identify is essential tremor is a kinetic tremor and a postural tremor is both are there, and both upper limb are involved. there can be asymmetry also. So usually the action tremor is seen when we are using the one hand. When we use the both hands to do something, the tremor get severity get less. That is a specific point in essential tremor. And as I told you, the simple test we can do to elicit this is arm extension, and we can ask the patient to draw the spiral. I'll show you what happens to the spiral in essential tremor. And pouring water test, drinking water, or we can ask the patient to use a spoon. And it's usually the tremor is said to be extension flexion tremor at the wrist joint. So this is the spiral in the essential tremor. This is a healthy control. As I think Dr. Chamila told me, in Parkinson, we get the smaller spirals, smaller one with the volume getting small. We call micrographia. I don't have the picture of that, I'm sorry. So when it's come to the essential tremor, if it is there for a long time, sometimes following may occur. For example, rest tremor. In long-standing diseases, they get rest tremor, and sometimes intention tremor. Not common, about like 44%. And head tremor they can get, and may affect ability to write, eat, drink, and self-care. And there are other associated conditions. For example, balance and gait difficulties. So that is the thing. When the essential tremor is there for a long time, the ataxic gait can be there. So we need to ask about the falls. And there is hearing loss also. Hearing loss in these patients are thought to be due to the cochlear pathology. It is not yet fully understood. Then study shows that 39% of this as a patient with essential tremor has this hearing disability. And it's a high frequency sensorineural hearing loss that they get. And most of the patients need hearing aids. So I think now you can remember the first patient in my presentation. He has the ataxia. So it can be most probably associated with his long-standing essential tremor. And other associated conditions are the cognitive impairment and the mental health problem. Because the long-standing disability and everything, the patients get anxiety and depression, and they get sleep disturbances, and the fatigue and the sensitivity to pain is increased. So usually when it's come to the primary care, we usually don't use a lot of investigations, but essential tremor is invariably a exclusion. So sometimes we need to do these checks depending on the history, not in each and every patient. So sometimes we need to check thyroid functions to exclude hyperthyroidism, and glucose levels, hypoglycemia, like that. Sometimes we need to do this testing. When it's come to the assessing the tremor, the severity in essential tremor, we can use this TETRAS tool. Here, there are things that we assess. Usually this is done in research things, not in the clinical practice, to see the efficacy of the drugs in essential tremor. So we can, this is the thing they have used to check the severity of the tremor. And when it's come to the treatment, the main thing is the lifestyle changes. and drug treatment. So when it's come to the lifestyle changes, because it gives a huge disability to the patient when the tremor progresses. Not in the first stage, but when the times goes, there's a huge disability. Maybe you have grandmothers or grandfathers with this condition. You can see their disabilities. So what we can do is ask them to have some modifications in their lifestyle. So it says that we can give the patient to hold things heavy, like pens or computer mouses, like heavy things, their tremor get reduced. Other than light things, we can, if it is let's see if it's a woman who's cooking, we can give her a saucepan, a heavy one, so that tremor get reduced. And as it is occurring when we are holding something, we can ask them to use a trolley or something to carry things, not by their hands, but put them into a trolley and carry them so that the tremor get reduced. And when in cooking, it's usually advised not to cook in cookers, but to heat food in microwaves so that patient won't get accidents like burn. And other than this, when in ironing, we can ask the patient to sit and keep the iron board in lower position and give the weight to the iron and iron so that the tremor get reduced. Like that, there are a lot of things in the lifestyle changes that we can do in patient with essential tremor. The main drug, first-line drug, is the propranolol. Initial dose is 40 milligram, 2 to 3 times a day. Maintenance is 80 to 160. And there it says that 55% of reduction of the tremor is seen. And even though it is not available in our country, the long-acting propranolol and the short-acting propranolol, there's two things, but it shows the same action. And there's another drug, it's primidone, and it's not available here. And when it's come to propranolol, it does not help with the head or voice tremor. But primidone can improve the voice tremor. And if the tremor doesn't respond to propranolol, usually another beta blocker won't work. So it's no point of changing the beta blocker. So we have to try something else like primidone. Other than the propranolol, there's low quality evidence for topiramate, alprazolam, clonazepam, and gabapentin. And there are other drugs like sonizumab, olanzapine, that usually, but these drugs are used in secondary care. So then if our patients are not responding to propranolol, we have to refer the patient, so the neurologist would start that. And it says that not to use levetiracetam and flunacinol, drugs like that, in treating with essential tremor. When it's come to secondary care treatment, it is beyond our limit. When we refer the patient, there are things like botulinum toxin that can be used, and deep brain stimulation, and thalamotomy, and MRI-guided unilateral thalamic thermoablation with ultrasound. Those are the high technical things that used to treat essential tremor. As Finas said, it's true that alcohol can suppress the essential tremor, but it is not a treatment for essential tremor. Sometimes people with essential tremor get addicted to alcohol because of this thing. But when we use the alcohol to reduce the tremor, it says it is rebound, because after 3 hours of consumption, we get the essential tremor more than the last time. So there's no point of taking alcohol, even though it reduces at that moment.
No, then we can diagnose the condition. That's yeah.
Yeah, you're right. You're right. We can ask the patient in history also whether you take alcohol, whether tremor goes away or not. That's right. We can get idea from the history. But some patients get addicted to it because, yeah, that's the problem. Okay, that's the end of my presentation. Do you have any questions? So I hope now you got the point that the ataxia can be there in essential tremor when it's there for a long time. So that's why my patient got that gait problem. That's what we thought after discussing with my trainer and with my colleagues and everything. That's what we thought. Anything you want to know?
Thank you so much, Gayatri. As you said, this is a very big presentation. We are having every day encountering patient with tremors. So many types of tremor. Among that, this essential tremor is
Yes,
very
and it is
common.
very difficult to diagnose the tremor.
Yes.
Also, yeah.
Thank you so much. This is an eye opener to us.
Thank you very much, Finas. That is very encouraging, your comment.
So, what is the primidone dose and how does it prescribe primidone?
Primidone, yes. Actually, Chaminda, I have the doses and everything. I can give it to you now also. I can't remember exactly the doses, but I have the BNF prescription with me. I will share it to the group. Is that okay?
Yeah, that's all okay. As a GP, we can prescribe propranolol and primidone both, isn't it?
Usually it's propranolol, the first line. Primidone in other countries also, in UK also, usually they don't prescribe at primary care. Usually it's propranolol. If it is not responding to propranolol, they refer the patient to the neurologist.
That is the referral point, no?
Yeah.
Thank you, Gayatri. It is very comprehensive presentation. Yes,
Thank you.
in addition to that, for your patient, to improve the handwriting, we can use wrist lifters. Wrist lifters is one kind of treatment option. Then
I see.
wrist lifters.
Okay, right.
Yes,
thank you.
Other thing is just a few things. It's been orthostatic tremors. It means when with prolonged standing position.
Standing position, yes.
Yes, mainly in the legs. Some believes that it's a variant of essential tremor. It means mainly.
No, it's another type of tremor, orthostatic tremor. Actually, we had a patient like that in our thing. Actually, we had each and every patient with tremor. And the last week I had psychogenic tremor also. And that orthostatic pressure patient, actually, he had the tremor when he was standing, and it reduces when he was walking. The exactly classical symptoms were there. And we had to refer him to the neurologist because it was very uncommon thing, and we had to get clear what it is. And we get the feedback referral and saying it is orthostatic pressure, and he has started him on clonazepam actually, and asked to review in 2 weeks, and we need to follow up what happens to that patient. Orthostatic tremor is also there. Yes, you are right.
Okay, other thing is rubral and humerus tremor. Humerus and rubral tremor is a kind of resting and occur also in action, both. It's because of midbrain and thalamic lesion. Then if a patient come with resting tremor, we have as a differential diagnosis, we have to think of others also. I think you mentioned midbrain, thalamic and lesion.
Yes,
A kind of
exactly.
rubral tremors, Humerus tremors.
Yeah,
Thank
yeah,
you.
they are rare, but they are in the list. You are right.
Yeah.
Yeah.
Yeah. Thank you very much.
Thank you very much for your feedback.
Gayatri, do you
Yes.
have anything to do with voice tremors? Can we refer them to speech therapist or anything? So baby, there's no definitive drugs for those.
Yeah, that propranolol, it says that propranolol doesn't help
Yeah.
for the voice tremor, the laryngeal tremor. Actually, I didn't come across anything for that thing. I think we all I think I need to look into that, whether is there any support for those patients. Yeah.
For the writing thing, can we
Yes.
use like a modified pen, like heavy?
Yeah, that says, that's what I told in the lifestyle. We can give them a heavy pen. Then the tremor get reduced.
Yeah, they can write
Yeah.
that.
And the other thing is, I don't know whether it's practical. Ask him to use his both hands when he's writing. It's very difficult because anyway, in one point it is, it is disability, but for some time we can help them with that.
You mean
Yeah.
using both hands?
Yeah, if we use both hands for something, the tremor gets reduced. That is, they are in the essential tremor. It's a pointer, specific pointer we can elicit in the patient with essential tremor.
Okay, thank you.
The one thing we can, when he's holding a cup, we can ask the patient to use your both hands other than one hand. So it get reduced.
But it is not going to apply for writing, no?
Yeah, I know. Yeah. You're right. And I have to thank Lalanta madam. Actually, she gave us a good knowledge about how to differentiate the tremors, which was a very difficult thing for all of us. And she corrected me everything word by word and slide by slide in this presentation. And thank you very much, madam.
Yeah, Gayatri, thank you very much for your presentation. The other thing is, what are the other signs of Wilson's disease? That is one question. The second thing is, so the person had a toxic gait, and then we have to look for cerebral signs. So the
Yes,
type,
madam.
you definitely, I know that you did it. Look for
Yeah.
look for nystagmus. With that, if there are any sort of changes in the eye, definitely you can catch, isn't it?
Yes,
So when you
madam.
look for nystagmus, so we have
Yes.
to look at the eyes very, very very closely, and if you see that it like case of facial rings are very characteristic because the color and the ways of all these things, and one by one you cannot look for anything, but as a whole, like if you look for nystagmus, you have to look for all the others, the positive signs in the eyes as well. So that
Yes,
is
madam.
do all the examination, not only for the tremors or whatever. That's the thing. So when you look at eyes, you have to look for everything. You have to look for ears, then the other rest of the. Otherwise, you can see the patient each and every disease, and I have to look for these, I have to look for that. No, you have to look for everything according to your differentials.
Yes.
Right? And the other thing is Wilson. So what are the other cardinal features of Wilson's? Not only that. So there are a few things, isn't it? So but what are the things you have to look for the Wilson's?
In Wilson's disease, in examination, there's
History.
Hello?
History.
Yeah, in history, the memory impairment and
Yeah.
and things and the features of chronic liver cell diseases.
Yeah, there are signs and symptoms suggestive of CLCD.
Yeah.
So then you have to look for, that's what I'm telling always. If you have some differential, you have to look for all the relevant symptoms and signs. Right? Not only just one. Because if you look for the nystagmus, you have to look for the vasopressure rings, because it's sort of the person doesn't come with any other symptoms suggestive of Wilson's, then no point of like telling this thing. But anyway, you have to you examine or you observe the eyes. You didn't see any of those. Like if you make that statement, that is enough, because otherwise you spend a lot of time when presenting things at the exam, especially. So you have to look for the main things, cardinal things relevant to the one, according to our differentials. Maybe for one disease, if you look, then you can exclude the others as well. And you didn't talk about this, this person has a congenital thing. Can you remember?
Yes, madam. Yes.
Kyphocoliosis, because it's also affecting us the balance, the both sides, because it's very badly affecting their posture and everything. It's also affecting his gait as well. Okay, then anyway, thank you very much for everything. It's nice because even today also I think there was a patient, and then I asked them, I think that Declan presented it, and I asked her to listen to today's presentation.
Yes, madam.
Was it helpful, Declani?
Yes, madam, a lot. Thank you very much, Gayatri.
It's my pleasure. Okay. Thank you very much. Good night, everybody.
Good night. Good night.
Good night.
Good
Good night,
night.
madam. Thank you.